All right, we are back after the presentation here and ready to bring in our panel to answer your questions. If you do have questions, please put them in the chat here. I'm joined by Dr. Dana Piasecki. Chris Gabriel is here with us, and then Margaret Lynch, a new face, who is a physician's assistant, easy for me to say, at OrthoCarolina. So the first question we have is for Chris. How often does an athlete need to do preventative exercises to see a benefit?
Most of the research recommends they're done about 2 to 3 times a week. So most programs can be done at the start of practice. So that's really an easy way to get it done consistently. But definitely 2 to 3 times a week. And we really try to start that in the preseason phase, just so they can get a good build up to the program to have done it about 6 weeks in total to start seeing some benefits.
And a follow-up to that is should a football player wear a protective knee brace when playing?
That's a great question. I'll kick that to Dr. Piasecki first or Margaret, and then I can kind of chime in after that. But I think knowing those folks, we're pretty much on the same page with this one.
So, Mike, the issue there with the brace, it's a controversial issue. I will say, if you talk to the brace companies, they'll tell you everybody on the planet ought to have a brace. The data is a little bit mixed. And when you really look at the studies, when it comes to bracing, there are a couple positions on the football field that may have some slight improvement in injury risk, but not necessarily for the ACL. It's usually for the MCL, actually, which is a ligament on the inside part of the knee that will heal fine, usually without surgery. And most of the linemen you'll see out there with braces, they're trying to prevent that type of an injury. But there's very little good evidence out there that wearing a brace when you play football or any high-risk sport actually prevents an ACL tear. But you do see a lot of brace use in the NFL. You see a lot of the coaches swear by braces. And so there may be an effect that we're just not seeing in the studies much, but I don't routinely recommend that athletes wear a brace to prevent an ACL injury.
Margaret, you have anything to add to that?
Yeah, well, I was a former athletic trainer before I became a PA, and bracing typically resulted in spending money, and then shortly thereafter, a quarter or so into the game, the brace would end up on the sideline with me. They're bulky, they're kind of heavy. Linemen, it was kind of a little bit like a security blanket, I think. They felt like they were a little more invincible in those, and so that may be some value, but for the most part, I would say that most braces are costly and then not widely used for a consistent amount of time.
I would say one comment on bracing, though. I think while it's not been shown, bracing has not been shown to prevent injury, it can sometimes be a nice little psychological boost for the athlete and the parents to feel like, this is going to help us get back. It's not necessary from a biomechanical standpoint in terms of the knee, but there is a little bit of a confidence boost that sometimes does come with a brace. So it's not a bad thing. But I agree with Margaret. It's not mandatory for everybody, and most people don't need it, but it can help a little.
Yeah, I see in college, almost across the board, you'll see offensive linemen wearing braces. It's like their coaches require them to. So let me ask you this. Will an athlete need a brace after surgery, Dr. P?
So that's a little bit controversial too, I'll be honest with you. Many different surgeons have many different approaches to that. Most of us do use bracing on some level, and I personally like to use a brace, which is a different brace than the one you might consider at the end of their recovery. But I do use a brace in the first 6 weeks or so afterwards. And it's actually not to protect the ACL graft, it's to protect the patient from themselves, because most of these athletes and really any patient that's had an ACL, the recovery is not miserable in the beginning, but it puts you down for a couple of weeks, and then you start feeling better, and you're often inspired to do more stuff than you should. I'll have my patients in my age group, they watch Chariots of Fire. You know about that movie, right, Mike? Chariots of Fire. I tell my younger athletes about that, and they're like, "What are you, 90?" Like they have no idea what I'm talking about. But you watch an inspirational movie early on, and you get inspired to do more than you're supposed to do. And so the brace sometimes it's a little check rein. It pulls you back in and says, "Look, I just had an operation here. I got to be kind of careful." So there is a brace. At least for me, I recommend using a brace in that early month and a half period after surgery.
Yeah, Chris, what is your experiences with with athletes using braces post surgery?
I think in the immediate post-op phase, I think it's fine as long as you're encouraging the athlete to come out of the brace, do their exercises, things of that sort, and really focus on getting their quad back. So I think as long as they're motivated to be consistent with their exercise and realize they just can't lay in the brace all the time and let time magically heal everything, I think that's the point I want to make. And then as far as bracing after return to sport, the thing I'd maybe add is a lot of people get a false sense of security when they have the brace, or they say to themselves, hey, I know I'm not 100%, I know I haven't passed all the tests, but just give me a brace and I can go back out there. And that's really not how it works. You still have to work just as hard. You still have to get your quad back. You still have to pass the tests. The brace isn't gonna make up for that. So the decision with a brace is a controversial one, but we still have to get all the strength back. We still have to pass the test, regardless of whether we choose to have a brace or not.
Yeah. Let's change subject. Go ahead, Dr. P.
No, I was just going to say those are great points. I think that's very true. I mean, everybody wants a quick fix and they want to get back in the easiest way possible, but there aren't any shortcuts in terms of effort and also time. It's one of the things we've learned a lot about recovery after ACL surgery. There's a lot of time involved, and there's a lot of time after you feel like you should be able to do it that you can't do it yet. And what we found in the studies looking at some of the return to sport parameters is a lot of athletes feel like they're ready to go back, even 6, 7, 8, 9 months sometimes, and actually they're not. And that's why seeing a really good physical therapist like Chris to really help with some of those maneuvers you saw earlier, so they can figure out, hey, look, I may feel good, but my knee's just not quite ready yet. The fastest way to go back in the beginning is to go slow, so that then you can go fast later.
Okay. I've got a question in the chat from Finley. It says her 13-year-old son just tore his ACL playing baseball. What would be your advice as far as surgery saving the growth plate versus waiting until he's older? He's very active.
Yeah, good question. So the issue with growth, the things that you're balancing there when it comes to kids that have open growth plates, you're balancing whatever growth they have left against the potential they're going to have another injury or cause damage to their knee if they play without an ACL. And when we've looked at that issue in young active kids, usually it's far more costly to not have surgery than if you do. So what happens if you just leave the knee alone and wait until the growth plates close, you tend to have more injuries, usually to the meniscus. In fact, probably about 90% of kids in the first year after an ACL tear that are adolescents like that will, if they ignore the ACL tear, and even if they're trying to hold back from doing aggressive things, will tend to have some type of abnormal twisting of the knee without that ACL in there, and they'll have a meniscus tear. And the meniscus, we know, as we talked about before, is very important for protecting the cartilage, and that can have really long-term implications for the rest of their lives, not just playing baseball now, but playing baseball with their own kids later. So the recommendation usually in active kids is to think about surgery. So there are ways you can manage the risk to the growth plates. And really, I think for most kids, particularly for boys at age 13, it depends a little bit on how mature their skeletal growth is. But there's probably not a ton of growth left. I'm sure there's some, but right around the knee, oftentimes there's not a whole lot of growth left at that age. There's some, but enough that you can work around the growth plates, or even do a special type of ACL reconstruction going through the growth plates to protect them in a way that minimizes the risk of a problem.
Okay. And Finley asked another question. After alternative surgery, do they need to go back in and have a regular repair when he gets older?
So what I think the reference there is to, there are two main approaches out there for dealing with the growth plates. One of them is to do actually just a normal, very well done ACL reconstruction, similar to what you would do if the patient was an adult. And the other is to do what's not really an anatomic reconstruction of the ACL. You kind of work around the edges and do a reconstruction that's not totally normal. At age 13, I think the argument would be to go for the real ACL. And what we find is that if you do a good job with it when you have 2 years or less of major growth remaining, which most 13-year-old boys do, they've got a couple years left, but it's not like they have 8 years of growth left. Usually, if you do a good ACL in that situation, you don't have to do it again. And if you do the alternative, which is kind of working around the edges, not really reconstructing the ACL, but putting a lot of restraints on the knee so that you just can't really be as active as you would otherwise be, that sometimes does require additional surgery in the future. So probably the best way to deal with it, in my opinion, usually if you're at that age, is to do just a really well done, careful, thoughtful ACL reconstruction.
Okay. Let's shift gears a little bit. I'll start with you, Dr. P, and then get to Chris and Margaret. A lot of people, or maybe it's an urban legend, I hear that teenage girls have more knee injuries than teenage boys. Is that true? And why do you think that is, if it is?
Well, specific to ACLs, it's definitely true. And if you look at the numbers of ACL tears that are out there, girls are probably up to 3 or 4 times more likely to have an ACL tear than boys. And there have been a lot of theories about why that is, whether there are some differences in the anatomy of the knee or if there's some hormonal differences that make soft tissues more loose jointed. And there may be something to that, but I personally think it has less to do with those differences and more with activity level. And we know, speaking even more to what Chris has really emphasized with how important the balance of muscles around the knee is for minimizing the forces that the ACL will see. I think it's the fact it's activity level probably that makes the biggest difference. So if you don't have the muscle balance to minimize the forces that go through the knee when you're active, you're more likely to tear an ACL. And I think the differences that we see mostly in adolescent high-risk sports like soccer, for instance, is that when girls are going through that developmental phase, they tend to put more forces through their ACL than boys do, bottom line. It's not like some problem with female ACLs. It's a physics issue. But we definitely do see it. And that doesn't mean girls shouldn't play those sports. Those are great sports. But it underscores how important it is to really focus on getting those muscles strong and balanced before the season starts so that you can minimize the risks.
Yeah, Chris, from your standpoint, with girls versus boys, what's the difference in the preventative and then the recovery?
Yeah, it's definitely a big issue we see with a lot of injuries with girls. You know, they tend to land with a little more valgus to where their knees buckle in. So not that boys don't do that to some level too. That's why it's important to screen everybody and see how they actually move. But getting the hips as strong as possible, hips and glutes, hamstrings and quads, all those muscles are really essential to decrease some of the stresses on the knee, regardless of the literature and back and forth, what factors are important. We want to make sure we're getting the muscular system and also the neurological system in terms of balance and motor control optimized to minimize these injury risks.
Margaret, what's your experience with this being an athlete?
Well, so, I mean, definitely soccer teams that I was on, I was one of the few people that didn't tear their ACL. But as an athletic trainer, too, seeing the ACLs come through, I think there are a couple of factors that play into it that they all talked about were the muscle imbalances. I think you also have to factor in a little bit that the females are going through some body changes at that time that predispose them a little bit to these muscle imbalances. And then also, as an athletic trainer and teacher, I used to catch girls. They love to stand with their knees hyperextended and locked. They shift their weight over to one side, jut their hip out, which kind of perpetuates, it tells those muscles, hey, I'm on vacation, I don't need to work. And then when you put them back into activity, like Chris is asking or talking about doing, I think it kind of predisposes them to a little bit of those injuries.
And how much of a role do hormones play when we're talking about girls' injuries?
Well, I think we don't know, right?
Yeah, we don't know. No, we don't know. I mean, there is some theory that estrogen and progesterone, the primary female hormones, have an impact on looseness of joints. But it's kind of weak. I mean, the problem is, like, you're seeing a rise in those hormones at the same time you're seeing these high level activities being played, and girls are going through growth spurts and dealing with all the forces that go along with high risk activities. So it's tricky to prove that there's an issue. And my personal suspicion is if there's an effect there, it's probably pretty small, and that most of it has to do with, just as I said before, just the physics, and that you're cool. If you're a girl, play soccer, it's good for you.
Okay. Getting back to surgery, is there ever a circumstance where an athlete may want to delay surgery and play through the season? And what's your advice on that?
Yeah, that's a tough one. So that's controversial. I think it really comes down to, and we're kind of making decisions about this every time we talk to patients, which is a balance of risk and benefit. What is the risk of playing with an ACL tear balanced against the benefit of finishing out the season, let's say. And that has a lot to do with what we know happens if you don't have an ACL tear and you play. It depends on the sport and the athlete. Most of the time, in my opinion, usually if you balance those factors out, it tends not to favor playing with an ACL tear because we know that it puts the meniscus and the cartilage at high risk. So, but it depends. I mean, you may have an athlete, I'll have athletes who are training for the Olympic Games and they're ready to go. It's Olympic trials and, it's a lifelong training approach they've taken, and maybe their activity, their sport is not super high risk, change direction type stuff. And it may be worth it to go ahead and play with that anyway. But if it's, you're a sophomore and it's a couple games left in the season and, it's you're not even sure you like playing soccer, I'd probably recommend sitting out, getting it fixed and not doing any more harm. So the answer is it's a balance. We always try to make a thoughtful decision for patients. It's not a one-size-fits-all approach. And we do try to balance how eager athletes are to get back, but we're balancing giving them a safe, healthy knee for the rest of their lives too. And that usually, most of the time, will outweigh the benefits of a partial season going back, at least in my opinion. But it's a tough call. We take it one patient at a time when we make those calls.
I used to always remind athletes that when we're young, we're writing checks that our bodies will cash in later. And you want to make sure that it's worth it. Because it's easy when you're 15 or 16 to make a decision because you are seeing the next month or two. But then when you're 35, 40 and you're dealing with the issues that came about, you gotta kind of weigh those risk benefits.
Mm-hmm. And I would say, I think that's a really good point. I mean, I think obviously, we make decisions for younger athletes with their parents in consultation. But when you look at what you see in our practices, we have the opportunity to see patients from young all the way through all different phases of life, all the way up until their 70s, 80s, and 90s. And that looking back for many of these patients really is something that they often will say, hey, look, I wish I hadn't done that, or I made a bad decision doing this. And those implications really do have a lifelong effect.
Chris, from a physical therapy standpoint, what's your view on delaying surgery?
Yeah, I think Dr. P hit it on the head. You've got to really consider the cartilage and the meniscus issue. A lot of people don't understand that. They think, well, my ACL is already torn. What else can happen? And they don't understand how hard it is once you destroy the cartilage and the meniscus. You're never the same. So, we want to protect that as much as possible. But again, it is a judgment call. And as long as everybody has all the information on the table, Margaret and Dr. P do a great job educating patients on this. If they make a thoughtful decision with their parents and the athletes and everybody knows the risk, I think there are some situations, whether that is a person we brace, whether it's somebody we take through a few functional tests to make sure the ACL, they can compensate for it with the neural system and muscular strengthening to make sure that, we're just not sending them back out there and make sure they do have some baseline control. Because it can make a big difference in a professional athlete, certainly a higher level athlete, maybe the last few games of the senior season where they're not going to play in college. So there are judgment calls, but in general, I think protecting the cartilage, people need to understand how important that is.
All right, very good. Dr. P, one last question for you. Do you think one graft choice within an autograft is superior?
So just a little background on that. I think we covered a little bit of this before, but as a review for the folks watching, you can get a graft is the tissue we use to make the ACL with. And when we do an ACL reconstruction, we're basically replacing the old ligament, making a new one. So the places you can get that graft tissue from a donor or from your own knee, if it's from your knee, there are a couple different choices of what you can use. The tissue that seems to work the best most of the time, in my opinion, this is another controversial issue. You take 10 sports surgeons and you put them in a room, you're going to have 10 different opinions on this. But my personal approach is that the patellar tendon graft, usually, if it is an option, tends to be a better option most of the time. And that's because it tends to give a more stable normal knee at the end of the full recovery, and it has the lowest re-tear rate still after 50, 60 years of these surgeries. It seems to be rising to the top every time it's looked at. But that doesn't mean there aren't other great options. And you can use a piece of your quadriceps tendon or your hamstrings. You could make an ACL out of almost anything in the body, truthfully. And if it's your tissue, there's a reasonable chance it would work okay. Excellent results have been reported for a lot of grafts. And so there are a lot of really good choices out there. I think it's one of my mentors in fellowship told me, this is back 15 years ago or so, said the type of graft you use is like the color Porsche you drive. And I'm not a car guy. I'm not into cars at all, actually. But, that underscores that most of these athletes are healthy, they're motivated. And if the surgery is done correctly, the majority of grafts will work really well. But my personal opinion, if I tore my ACL, for instance, I'd use the patellar tendon graft, because I do think there are some subtle benefits there that it's not for everybody. Sometimes a hamstring will be a little bit better of a choice, but there are small differences.
With the exception, like the one he was talking about, a better choice is like if the Finley that has open physes or growth plates, with those typically you'd pick the hamstring graft for those.
Yeah, that's correct. I mean, there are issues that would make other grafts better. And Margaret's right. When we have open growth plates, one of the ways that we can deal with that and still do a one-time ACL that should last and work great is to use a soft tissue graft instead of the patellar tendon. The patellar tendon graft has a tiny little piece of bone on both sides of it. That's one of the reasons it works really well in adults, is it heals quickly and securely, versus the soft tissue grafts, which are like a tendon that's put in the bone, and you ask the tendon to heal into the bone. It can be just a little harder to get the healing. But if you balance that against the growth plate issue for younger kids, a hamstring graft tends to be a superior choice in that situation.
All right, terrific. Well, guys, we're out of time. Want to thank everybody for tuning in. Dr. P, if somebody wants to make an appointment to come see you, how do they do that?
Well, if you just call OrthoCarolina and just ask, I mean, we've got a lot of great sports providers there. Of course, I'm one of them, but there are lots of us in our OrthoCarolina Sports Medicine Center. And I think it's just you can look online actually and schedule an appointment through our website now. So just go to orthocarolina.com, and there's a phone number there as well as a way to access our appointment scheduling digitally.
Chris, what about you if somebody wants to come in and get an assessment?
Yeah, really the same thing, orthocarolina.com. It's really easy. You can search all the therapists in your area. And it's pretty easy. Just go through the website, and we'd be happy to take a look at you and help out however we can.
All right, guys. Well, thank you for your time tonight. Thank you for everybody that tuned in and watched. We will continue this series in the coming weeks, so keep your eyes open for it. If you have any suggestions about topics you want to hear about, please put them in a chat. And panel, thank you a lot, and we will talk to you later.
Thanks, Mike.
Thanks, guys.
Thanks, everyone.